Welcome to Getting Wired, Decoding Neurointervention, the podcast that takes you inside the world of cutting-edge neurovascular care. Hosted by Dr. Rajeev Sivasankar, a highly experienced interventional neuroradiologist, this series is dedicated to unraveling the techniques, innovations, and real-world challenges of neurointervention. Each episode features in-depth discussions, expert insights, and case-based learning from some of the most experienced masters in the field. From advanced procedural techniques to the latest breakthroughs, this is the go-to resource for specialists looking to refine their skills and stay ahead in the ever-evolving landscape of neurovascular intervention. Get ready to learn, explore, and master the art of neurointervention. This is Getting Wired.
So hello friends and welcome to another episode of Getting Wired. And today is a very special episode. And it's going to be a conversation tailored on what's something neurointerventionists always wanted to ask but didn't know whom to ask. So to help us fill some lacuna in knowledge on stent retrievers, we have gathered together a panel of experts. And it's a pleasant privilege of mine to invite Jeff Kosinski, who is the Director of Neurovascular Affairs of the Australia, New Zealand, and Asian regions. Welcome, Jeff, to the show. We also have Cheki Sagic, who is the Product Global Specialist of Bolt International from Israel. Hello, Cheki, and welcome. It's a pleasure to invite Annalisa Smullen, who is the Senior Medical Consultant for the J&J Cerenovus division from Ireland. Welcome to the show, Annalisa. And finally, warm welcome to my friend Shashwat Desai. Dr. Shashwat is the Medical Director of the Honors Health Lab. He is also the co-founder and Chief Technology Officer of Gravity Medicals, in addition to being the Associate Professor of the School of Medicine at the Arizona State University. So welcome, Shashwat, to the show.
Good to be here. Thank you.
So today we have four specialists in the space of something that we neurointerventionists use every day, and that is stent retrievers. And do we really think about which stent retriever we need to use, or do we use anything that's on our shelves? Does it matter? Does the size really matter? Do we pay a second thought about what length we need to choose, or do we go in for our regular spinal level 640s or 630s? So these are some of the questions that we're going to try and probe into our R&D specialist minds and learn from them. So starting off with you, Jeff, you guys are the OG SR manufacturers. You all are the ones who came up with the Solitaire, which was the first commercially successful stent retriever after the Mercy device era. So tell us about that. How did the concept of stent retrieval start? How did Solitaire come into being? You'll start it off with the Solitaire AB, then move into the FR, then move into the X. So tell us something about that.
Yeah, well, thank you for the invitation, and that's quite a nice way to open up the podcast, calling the Solitaire the OG of stent retrievers, because that's absolutely true. When you go back to 2007, 2008, right, give or take a year, there wasn't a lot of tools in the thrombectomy space, and in fact, stroke wasn't really treated that commonly around the world at that time. But in that time frame, the tools that were available, I don't think the results were particularly good. And there were physicians, neurointerventionists then around the world, all at around the same time, that were looking to different technologies, different tools to, retrieve clots in a more effective way. And Solitaire AB, AB standing for aneurysm bridging, was a stent that was widely available all around the world. That was, in the EV3 or COVIDian years before we became Medtronic. But that stent was available all around the world, and a number of neurointerventionalists then started to have this idea that because this stent was fully deployable and then fully retrievable, which was a feature that was not available with other stents at that time, the notion came into physicians' minds that you could deploy a stent the Solitaire AB stent into a clot and then retrieve it. And what we were finding in different parts all around the world is that when the stent was retrieved, the clot came with it. So it was kind of like that aha moment, right? Where, this stent, even though it wasn't indicated or intended for that particular use, was doing something rather wonderful and was getting better results in retrieving a clot than some of the other technologies that were available at that time. And so I think we kind of fell into it by a lucky accident. It was a device that wasn't intended for that purpose, but served a great need at that time. And we've made some changes to the device over, the years that have followed, but fundamentally those same design parameters still hold true, many, many years later with the other iterations, Solitaire FR, Solitaire 2, Solitaire X, right? We've made a few changes over the years, but the fundamental principles still remain true to what the device is that we had, 20 plus years ago.
All right. So the question I had to Cheki was that, as an R&D specialist, when you consider a stent retriever, you have to take into account the radial force, the cell size, the size of the, how many microns thick should the wires be, whether it should be laser cut, what should be the chronic outward force, what should be the clot integrating potential. So when you look at so many parameters together, how do you actually come out with the answer of, what's the ideal device? What's the sweet spot? What's the holy grail in stent retrievers? How do you come out with that and that answer?
Okay, thank you. Thank you for this question. Well, we start from the famous term, let's say, the radial force. Okay, so that's the most overused term, in my understanding, in the market for all sorts of devices, not only for stent retrievers, maybe for the flow diverters, for the stents, for anything. So it behaves differently depending on the clot phenotype, in my understanding. Okay, we'd say red clots, which are softer and more deformable, too much radial force will not be as beneficial. Or I would say there is nothing bad with that, but we not add much of benefit. Okay, the clot can deform, could be compressed and integrate relatively easily to the SR surface or the cells. With fiber-rich clots, it's different. The clot is lower, less deformable, and often requires more sustained device-clot interaction. In this situation, geometry, cell design, and the clot retention to the device becomes very important because it's just not grabbing or integrating it. You have to retain it to retrieve also. Okay, and the calcified emboli are different. They behave more like rigid bodies, like the foreign bodies, like iatrogenic, you lose the coil or part of the device and you want to retrieve it. Similar to that, increasing the radial force alone may not solve the problem again because the device may not penetrate or integrate the clot effectively. Then the friction or the length of the device may work, or you have to employ different techniques to retrieve or engage the clot in this situation. So the radial force should not be discussed as an isolated number. Like I think all the experts here, it's very easy to increase the radial force of the devices for different with different known engineering techniques. You can make the strongest, beefiest device ever, but then it will not work for the purpose. So it only has meaning when we know the clot, vessel diameter, the deployment diameter, and the retrieval path, if it's curvy, if it's too distal, if it's too proximal. And for me, radial force without the clot context and the localization within the brain is an incomplete discussion. And also the technique. You have to employ like combination of the aspiration catheter, double stent retriever, and you can increase the numbers of the techniques.
But when you do manufacture a stent retriever, you have to make a decision that I need a finite amount of radial force so that it is strong enough, but not it cannot damage the endothelium. You have to make a decision on the cell size. You have to make a decision on the strut thickness. So these are things which you have to pre-decide before you go into manufacture, right? So how do you do that is my question.
Definitely. So, for example, you wanna reach to M3. It means you have to deliver your the stent retriever to M3, or say distal PCA. Okay, so the crossing profile matters here. So you have to be compatible with the small microcatheters, like 17 microcatheter, or even today we are talking about 0.013 microcatheters in the market. To get there easy and to deliver your stent retriever through that microcatheter without any hassle, without employing many more support techniques that you will lose time at 3 a.m. in the morning, and then it might be also traumatic for the patient, for dissections, for vasospasm in the cervical area, and so on. So that's important, the crossing profile and structuredness. And the radial force is important. But as I said, according to the region, if it's a large vessel occlusion, or depending on the clot type, you need to have stronger devices. And if you're in a small vessel, the radial force works against you. So there is a balance here, and you have to customize your stent retrievers according to the clot and according to the vessel you are working on. Plus the cell structure. I believe in general, the market, we have learned a lot throughout these years, and we are reaching a plateau to understand the cell structure. I can see my colleagues here from different companies. They have perfect devices. So today we are using the longitudinal slit design, which the stent retriever overlaps onto itself. And this way, if there is tapering on the vessel, then the cells remain still big enough to engage more clot, and then you will have safer retrieval.
Annalisa, so J&J embarked on the journey, and you had, I think, the Revive, and then the Embotrap 1, 2, Nimbus coming up. So obviously, every company has come out with iterations of a device. So there is a constant learning and implementation of those learnings into a device. What are your thoughts on your journey in Cerenovus? What have you learned about stent retriever design? But what's really important about the core principle of SR design?
Yeah, it's a good question, and I think it goes back to a lot of what the other two have been saying. We look at the early stent retrievers, and a lot of them were these happy accidents. They were stents on a stick, and they relied on radial force. They relied on friction to pull back the clot. And what we've learned really is that you need to do more than just push the clot out, more than just use radial force to hold the clot in place. You need to understand how the device and the clot are going to interact together in order to get better control. And so the early days of our company, which started as a startup here in Galway called Neurovi, the focus was, let's understand clots. Let's understand the anatomical conditions. What's happening to the clots? Do they change over time? How are they being formed? Are there properties being impacted when we interact with the clot and the device? Do they change in that moment? And only when we can understand the clot science, understand how can we recreate these clots repeatedly in the labs that we can test as much as possible. Only once we can get there can we start to design a device that looks different or acts different from what is already available. And that is really what kicked off the Embotrap design. So the Embotrap design, the focus was not just on active trapping, but it was focused on active trapping, not just passive dragging. It really used the principles of clot science and the anatomy to put together this design. And like all things, we iterate over time. So we make small tweaks to the designs to take us from Embotrap to Embotrap 2 to Embotrap 3. A lot of those design refinements you can't see in by eye. They're really quite small changes that seem to have a significant impact on embolic control and the first pass effect. And the more we learn about clots, We also learned more about how, there's a need to adapt your technique and your device to the clot biology, not just the anatomy. So you mentioned Nimbus. It came from that realization that not all clots are going to behave the same. And so not all stent designs should be the same. And there's this market where we want to match the stent design to the clot type. So for the tough fibrin-rich clots, that's where Nimbus comes in, rather than focusing on capturing the clot. We're trying to mechanically grip and engage the clot. These are clots that tend to want to adhere to the wall, don't like integrating into your typical stent retriever design. So, I think the progression just shows that we've gone from focusing on let's just engage the clot to let's capture and control it and manage that clot, to designs that are specific to a clot phenotype or clot biology.
Okay, so what I'm hearing is that contrary to popular understanding, it's not the radial force, it's more to do with the anatomy and the clot biology that decision making should be centered, which brings me to Shashwat. So Shashwat, we have so many devices in our armamentarium, and you from Gravity Medical has come out with another new device which is tailored to Asian problems and Asian strokes. So can you tell us a little more about this as to what gave you that idea, and what do you think is going to be answered by Supernova, your device,
Yeah,
as opposed to the other devices?
absolutely agree with all the comments before from all the panelists. But one fundamental problem with contemporary stent retriever technology has been that TK3 rates, which is complete recanalization, are in the range of 50 to 60% at best. And first pass rates, probably 40 to 50%. And if you compare this to a very well-established field like interventional cardiology, they have TIMI3 rates, which are reaching 90, 95%. So there is a wide gap which is yet unmet in neuro stent retrievers as compared to stent technology elsewhere in the body. So we have improvements to make. When we started designing our stent retriever, Supernova, we actually totally agreed that clot composition affects recanalization rates. But our solution in the form of Supernova is that we want one size fits all. We don't want to make a stent retriever which is specific for a red clot, or a stent retriever or a different device specific for a tough clot. Because acute stroke is a highly time-sensitive intervention. And as of today, we do not have any reliable method to know what clot we are dealing with before we engage the clot and we do the first pass. Even after the first pass, if we don't see recanalization, we just grossly look at the clot, we make a guess. We really don't know histology of the clot until we go in the lab and see, and there is no time for that. Yes, some would argue there are tools now like the sensome wire, or some imaging markers that, oh, this may be a fibrin-rich clot, or if you see a hyperdense on a non-con, you would think this is a red blood cell-rich clot, and you could tailor your treatment. But at 2 a.m. in the morning, when you're doing a stroke, you want to make the procedure as simple as possible. You don't want to introduce more devices because that adds to the step in the procedure. It adds to the cost of the procedure. So if you want a device which actually is one size fits all, a device, a stent retriever, which can deal equally well with red clot and with white clot. Contemporary stent retrievers are researched and developed very well actually in the West, where a predominant chunk of the population is Caucasian, where most of the clots are red clots. Our work in the US, in India, in Thailand, Asia, we know that ICAD is more common in Asia. It is there in the West as well, but much less common. So the types of clots we encounter are different. So the thesis behind Supernova is that we wanted to work very well against red clot, work very well against white clot, and work very well against thrombectomy in the setting of ICAD. So that was our design principles, and that's the gap we're trying to bridge.
Yeah, interesting. Right. So, Jeff, coming back to you, can you take us through the design principles and the concepts of the Solitaire, the current generation, as to what kind of design is it based on, and just run us through the details?
Yeah, sure. Happy to do that. As I mentioned at the beginning, our entire stent platform was built on the Solitaire AB technology, and that, similar to what Jackie mentioned earlier with a longitudinal slit design, we have a very similar technology, and it's a parametric design. So the stent folds over itself, and that's what allows it to be fully retrievable, right? 20 years ago, that was revolutionary. Now it's pretty standard across many different stents that you see on the market. But that, I think, is still one of the key, distinguishing features of the Solitaire stent. Another would be, a 6x40 size, so a large diameter, long length. I think it speaks a little bit to Shashvat's comments there around simplicity in the offering as well. You don't need to overcomplicate things. So I think the parametric design, the simplicity in the setup and how it's used, obviously all stent retrievers, or at least most of them, would be on a self-expanding Nitonol platform, right? That also adds to ease of use. It's less prone to manipulation and other techniques that the operator might need to input into the equation. And so I think that would be, some of the key features that, were true of Solitaire in the beginning. As we've made iteration improvements over the number of years, there's small changes that we've made, the delivery wire, visibility, things like that. But ultimately, at the end of it, the parametric design, the ability to overlap a stent and not have to be overly particular about the sizing and choosing that vessel, a stent to match the vessel diameter, and having a little bit of flexibility there. So you don't have to overthink it. You can move in with a stent and have that overlapping design, just conform more in a smaller vessel, integrate with a clot in multiple planes. That's been a key differentiator for us for many years.
Yeah, I agree. For many years, we've been using the 640s, even in the proximal M2, mid M2s, and it's worked really well. And that's before so many SRs came into the market. So I completely agree with you. Like it's been the go-to SR for so many neurointerventions globally because of its design and the sizing and the safety. We honestly didn't have any dissections or bleeds that I can even think of.
Yeah. That balance of radial force then in clinical performance, it's really important. Of course, all of the companies, manage that in all of their R&D testing, but it's certainly nice when that translates into clinical practice and that balance with safety is accomplished.
True. Chicky, how about you? Can you take us through the differences between in your design? And I know, for example, Solitaire has a 640. You got a design which is a little different. It comes like a Catch Maxi comes with a 5.540 or a 5.550. You have a very long length too. And you have a profile which is a little lower than the other SRs. So can you tell us something about your design concepts and why you've gone a little different from, say, a Solitaire?
Okay, thank you. So cash view is like Solitaire in this case, or like the other mainstream stent retriever, is a Nitonol tube, laser cut, with different variable cell structure, self-expandable, fully resheathable, closed cell stent retriever with a longitudinal slits along the device. So what we care is the control deployment. It should be predictable. As Shalshat said, 2 a.m. or 3 a.m. in the morning, you want predictability and ease of use. You don't want to mess with tips and tricks and all sorts of stuff. We are focusing on reinforced non-kinking delivery wire because you have some elder patients, some tortuosity, some herniations to pockets in the vessels. So we care about that, the deliverability part, strong visibility from platinum, and integrated tantalum body markers over the body, and compatibility with smaller microcatheter systems of 21 for 6 mm, 17 for 4 mm, and even 13 is mentioned in several studies today. And although it's not officially recommended by the company, the legal teams, but it's widely used within the field, I think also in India. So the Cashview Maxi, I think you're relating, is a 6 mm. So it provides options for, of course, larger vessels. But as you said, in real life, you are using up to proximal M2 or partially M2 tapering down to distal ICA. So yes, it includes longer lengths such as 50 mm, the usable length, and the total length is 67 mm. And Cashew Mini, the 4 mm going to 17 or 13, addresses distal and medium vessels. And this is our platform. And if you're asking why you're opting for 50, but although the 40 works perfect. So for us, length is about coverage and integration and force distribution. Okay, so we also have the 40 mm version, which is the mainstream SR length, works in almost most of the scenarios. Okay, but as my colleagues here will also relate, when you have a longer stent, then the radial force is distributed evenly in a longer segment because it is inherently losing it towards the end of the stent. Okay, and the angiography or the other advanced techniques that we have often underestimates the clot length. A longer retriever can increase the contact zone with the clot, improve the anchoring, and distribute radial forces over a longer segment rather than concentrating them on a short focal section. I am not saying the 40 is short, but 30 might be short as a mainstream stent retriever most of the time, at least in our experience. And that is the logic behind offering different lengths, including 40 and 50 mm option with Maxi. But I would not blindly say longer is always better here. In distal or fragile anatomy or tortuous anatomy, unnecessary length may increase the vessel traction, your anchoring, the anchoring that you don't want to happen. The key is not maximum length. The key is having the right length for clot burden and the anatomy. So the value of multiple length is the adaptation to your case, and longer is not always better. For us, the appropriate coverage of the clot is better.
Right, but sometimes in many cases we do know what is the length of the clot. Like for example, on a collateral CT or even if you do your angio and it's a short 12 mm clot or 15 mm clot, it's middle it and it's fine. But suppose you have an occlusion or a pseudo occlusion of the ICA and you're blind up and you've got, you don't really know what's causing it. And your SWI MRI shows you that there is suppose a clot in the M2, there's nothing in the M1, you're not seeing anything. And that's the kind of situation we find ourselves in, especially in Asian populations where there's a lot of clot burden, there's atrial fibrillation, they've thrown up one bunch of clots into the M2s, one bunch in the ICA top and M1s, and some in the cavernous ICAs, plugging the whole system. So these are situations where we are blind as operators and we really don't know what kind of clot length we're looking at. So in this situation, would you say that when we really don't know what we are dealing with, would it be good to upfront go with the longer length and open it and see how it's going? Or we've also done the I type, the piping. We deploy 2 stent retrievers in tandem and open the whole system out and see exactly what we're dealing with. So what do you suggest as an engineer? What is the downside of pulling it? Will I increase the risk of dissection, vasospasm, or bleeds? What are your thoughts?
Excellent question. Very high level. I will try my best to respond. Okay, so exactly. This is why 50 is used widely for the lesions that you cannot predict the ending of the clot's length, and because of the high clot burden, you want to opt for the longest possible. But the challenge of using longest possible is to bring that device to that location. So if it starts from proximal M2 and extending down to ICA, then you want to care about the M2 part. You want to go there with a 27 catheter or a larger catheter. Probably you don't want to aspirate with a large bore catheter on this region. So 21 microcatheter compatibility with this, I would say, the giant device and strong device is the key in our engineering goal. So if you can get there and your daily 21 catheter that you like, you prefer, and deliver the big stent retriever easily, so that's a good thing. That's it will allow you to achieve that result. Second, the overlapping design, because the device overlaps, it will try to retain its cell size. Similar, I would not say 100% the same, but similar in the 2.5 mm vessel versus the 4 mm vessel. So device can perform all along the deployment path in a similar performance to engage the clot and bring it as a whole piece, hopefully in the first pass. And when you are retrieving the long device, there are different techniques that you are already, I think, mastering in India in your personal practice. That, of course, you can partially resheath the device, use the pinching technique. That you shorten the device and leaving only the effective length by locking the clot, also helping you not to have like fragments or secondary emboli to distal vasculature, and bring the device in a safer way. And also, of course, the more distal you are going, or the longer device you are using, you will have challenges in the curves when you're retrieving the device. And within the curves, that longitudinal slit and shape of the cells will also help you not to lose the clot and engagement in the curves due to the elongation of the stent retriever.
All right. So because yours is closed cell, so it retains the cell shape, and which is why it prevents the losing. All right. Thanks. That's a good answer. Annalisa, Embotrap has a very unique design, which is very different from every other SR that we know of. So tell us something about that, about the design of the cylindrical hypertube, the petals, and what made you come up with that kind of design, and the Nimbus too.
Sure. Yeah. So we'll start with Embotrap. As you mentioned, there's two tubes to it. So it does look quite different. We have what we call the outer cage, and we have the inner channel. And the outer cage, the intent there is to have these large window openings. You would allow the clot to enter into the stent, really engage with the clot. And then when you pull back on the stent retriever, that outer cage with those petals stays open and helps you kind of navigate along the vessel. Inside that, then, it's paired with another component that's called our inner channel. And the inner channel is there to really stick onto the clot. The clot enters in through this outer cage, grabs onto the inner channel, and it maintains that engagement as you're pulling back. It's what's keeping the clot from just flopping back out as you go around a bend or a side branch. Those two pieces in combination then are brought together at the distal end. So it's a closed distal end with what we call a distal mesh. The idea with the closed distal mesh at the end is to try to mitigate the risk of any fragmentation, clot rolling. You just get another chance to catch the clot if you need it. And it goes back to kind of understanding how clots interact in the vessel and the different clot types. It's like everybody said, you don't want to be messing around in the middle of the night trying to decide what device you should use, figuring out what clot type it is when you really are just looking at a black and white image. So trying to come up with something that'll work in the majority of cases, the majority of clot types, is what led to this two component piece, and really, taking a lot of the learnings from the earlier stent designs with these open cells and these engagement areas, and combining it with the stability feature in the center. And then similar to a lot of the other devices, there's the distal marker, proximal markers throughout the stent, features there to allow you to see where you're placing the device, all connected back into your pusher wire. But that two component design is quite unique to Embotrap. It's different than for Nimbus. So Nimbus is back to a one piece design. And what's unique in Nimbus is that while it's one piece, there's two distinct designs in that one piece. So the proximal end we call a spiral, and that section of device is intended to operate this pinch technique where you can physically grab onto the clot and pluck it out. Whereas the distal section we call the barrel, that's giving you control. That's stability as you're retrieving it, stability as you're deploying it, kind of keeping everything centered in the vessel. So the two devices do look quite different. They're designed in very different ways to look at different procedural challenges. I think Embotrap this is going to be your first pass. This is going to work in the majority of clots, whereas Nimbus is really designed for, you've tried everything. You've thrown the kitchen sink at this procedure, at this patient. It's not working. Let's plot a rescue device and see if there's something going on here that your standard Embotrap Stent Retriever can't handle. I think there's some cases where you might use Nimbus up front, and if you've got a really good idea that it's a challenging clot you're dealing with, but for the most of the time, it's there when everything else has failed, and you need to just try something different.
Sounds interesting. Now, Shashwat, coming to the Supernova. So do you, I like the concept that you came out with of trying to keep it simple, because we all hate those 2mm cases. And we hate having the first pass, just pull out some fragment, clean the device, go back in. It's always a pain, and great to have a clot out first pass. So can you take us through the design philosophy of Supernova?
Yeah. So 5 years ago, when we started building the Supernova, our goal was to build a device which truly democratizes access to stroke care. And by that, I mean to take access to thrombectomy from a global average of 2% to the required access of 70-80%, which is normal for a medical device. And that would mean that the device would be used all over the world, not just in some pockets in the West. And because of our goal to be used everywhere, we had to make sure that the device can work across ethnicities, across resource environments, across level of training, across different kind of cath lab resources. So the goal really was to create a democratic device which works for different clots, different patients, different cost environments, and different stroke etiologies. With that in mind, we really leveraged virtual simulation earlier on to inform device design before actually going to prototyping. And that led to a great collaboration with a great university in Europe. And we were able to classify different clot types, create an atlas of different clot types which we see in the West, in Asia, in India. And our focus was to have the best clot engagement possible with the Stent Retriever. And the culmination of those efforts is the design thinking behind Supernova. And what we've built is we have extremely large cell sizes, which essentially means there is very little metal in the Supernova device. It's very low profile, very thin struts, and large cells means less fragmentation of the clot, which also means less chance of distal emboli or in new or other areas. Also, very thin struts with a similar radial force means better pressure, better engagement of the clot. And the unique feature which we've incorporated is relatively higher radial force in the middle 60% of the stent, the clot engaging segment, and lower radial force in the proximal 20% and the distal 20%. So this affords us a overall net low radial force while maintaining clot engagement efficacy in the middle high radial force region. And as everyone mentioned, and I totally agree with them, that a Stent Retriever is, as a medical device, it has to be safe and has to be effective too. So the art is to find that sweet spot of engaging the clot without creating trauma on the vessel. And I think that is the thesis behind Supernova.
And technically, how do you increase the radial force in the center?
Yeah.
And what is the...
So there are, and I'm sure the engineers can answer it better than I am because I don't come from an engineering background. But clinically speaking, and from what we've learned over the years, multiple parameters affect the radial force of a stent. And this is very well described in cardiology. First and foremost is the shape of the cells, the angle between the struts, if you look at the cross section of the strut of a stent retriever, it has a ratio to it, right? It's a square or a rectangle in the cross section, and if you increase the width, you increase the radial force. The thickness can also impact the radial force. After you laser cut it to your design, that you fix some aspects of the radial force already in the stent retriever. Beyond that, when you provide heat settings to it, to set the nitonol at a particular shape with the AF temperature, which provides it that shape memory alloy effect, that also has some impact on the radial force. So the way we tailor our radial force to be more in the middle and less towards the ends is by having a differential design in the middle compared to the proximal and distal ends
In your cell structure.
in our cell structure.
Gotcha, which is why the radial force differs.
Correct.
Okay. Okay, so we have, as you have heard, we have differing philosophies, but all with the same intent of integrating with the clot and keeping it as safe in maximal of our cases. Whilst you develop and go to the next generation and the next generation, do you actually think that there are certain trade-offs you have to make during development? Like you will give up a certain parameter to improve, say, clot integration, you have to give up something else? Or do you think that, we can come in the future with a device which has got all the good properties?
Yeah. So I guess, thanks for the question. I guess you're kind of asking, theoretically, could we design a perfect stent retriever that covers all aspects of stroke? And, I don't know what the answer is necessarily to that, but I think in our product design, there's trade-offs that we always have to make on, cell sizes and struts and all the rest, and also compatibility with aspiration catheters, right? There's certainly been a shift, of course, to an aspiration first technique in a lot of cases, or whether that's a combined therapy or whatnot. There's a balance with device performance that I think has to be, measured more than just, the stent retriever itself, but how it interacts with accessory devices and also other things that are going on. I totally appreciate some of the comments earlier around, we've hit maybe a little bit of a plateau with, TICI 3 scores, first pass effect rates. Can we improve? I think, all of us as an industry can find ways to continue to innovate with devices. But I sense that we have hit a little bit of a plateau. So what is that, next, inflection point that drives improvement in clinical performance? I guess that's part of this podcast, right? To talk about what that could be. I think we're all trying to figure that out. A lot of the, future improvements, I think, might also just be outside of just stent design, right? The technology, as much as it can improve, is pretty darn good today. It's, I think across the industry, all neurointerventionalists have access to very good tools to retrieve clots. So what is next? Is it maybe an interaction with, a drug or neuroprotection? Or, the whole field could be considered in different ways. So I think there'll be a lot of innovation that comes outside of just stent design.
So all the panelists here, I'll throw this open to you all. Do you all think that, along with Jeff, do you all align with that idea that we have come to a certain degree of plateauing as far as stent retriever design is where we are at right now, and maybe the bettering of TICI 3s or first pass efficacy is going to be more about the operator driven techniques or the combinations or the megabore catheters?
I can go first.
Yeah, please share.
Yeah, I think the plane and the pilot both are important. We need better techniques. We need better adjunctive therapies with a stent retriever. But as with any technology, this is the course of natural history of a tech. We make phenomenal progress, and there is some plateau. And as Jeff mentioned, there will be some inflection point, and we'll see another round of progress. And this has been seen across surgical fields. We went from open surgery, there's a plateau, laparoscopic surgery, plateau, robotic surgery. So I think we are probably waiting for the next inflection point. And my firm belief is that stent retrievers will continue to evolve. They may look different 5 years from now or 10 years from now. They may have more mechanisms to engage the clot, not just mechanical. It could be an enzyme. It could be a drug on it, as Jeff mentioned, or it could be a completely different material. The amount of progress in material science is actually unknown to the clinical field. And when we see, we may have a graphene-based stent retriever, or we may have a new composite which is carbon fiber made. So I think if we solely stick to the nitinol realm, then we are limiting our thought process. But there will be progress.
Yes. Shaky, what are your thoughts on the future? Surface coating, addition molecules. Can we have something which releases TPA or tenecteplase out there? What do you think is the future?
I think all of us has some words to say, but legally we are limited to say.
Okay, say what you can say legally.
We try to give some small hints, but we have to be very careful here. So I want to start my response with a more conceptual and maybe summarizing what we all try to say. That's, we are concentrating now. We are talking about a stent retriever, the device, the tip of the iceberg itself. Okay, but say you make the best device mechanically. Plus, in the future, with the different surface treatments or different drugs bonded to that, on so on, or I don't know, maybe magnetic stuff, maybe robotic stuff. But even it can capture the clot well, but not delivering safely down to outside, then it means it fails. The best device can fail, and even you can deliver it, but it's not visible enough and you cannot position it well, the best device, again, it will fail. And the deployment point of view will be very uncertain. Even it has the strongest radial force, best clot engagement, but it creates trauma in the vessels, then it's not a success. Even you take out everything, including some endothelium. So I think it's the innovation has to come from the gaps that today we should address. Like you have the perfect device, you can get the clot out, first place attack, 100%. That means you are trading off with the safety. So innovation shouldn't be focused only the strength of the device or I would say the talent or performance of the device itself. It's a complete package. And the techniques that should be employed accordingly, the operator techniques should be employed accordingly. But well, the next improvement probably will come from the more not the mechanical things, but the biologic or the bonding or the coating of the devices. That's the easier path, I would say.
Yeah. Right. So, Annalise, I have a question for you. Why is it that most devices are 6 mm in diameter? Why did we choose this specific number? Why not? Is there a physics to it or a biology to it, the kind of oversizing, or did we plan keeping the M1 in mind? So I'm talking only about the diameter. For large vessel occlusion, why was 6 mm chosen?
Yeah, I think we probably all have different data to support what number exactly we've chosen. Embotrap is 6.5. There's a 6 mil. There's all these different variations, and I think for us, what it came down to is what is the diameter of an M1? How much radial force do you want to apply to an M1 vessel? But then also, what are the diameters of the vessels that you're pulling the clot back to? So say you can't get your intermediate catheter as distal as you want to. If you park your intermediate catheter in the ICA, what vessels are you navigating through? What are the dimensions there? Because you don't want to have your clot or your stent no longer fill the vessel as you're dragging it back. It's just a chance for the clot to be dislodged. So I think it takes into account a few different pieces of the anatomy. How big can we keep it so that if you're pulling it back into the ICA, you still have your stent touching the vessel walls and the clot engaged, but minimizing it so that if you're in an M1 or if you deploy the proximal end of a long stent in an M1, you're going to have stent in the M2, possibly in the M3. So you're going even smaller vessels that you probably can't see, that you probably don't know what their actual diameter is, and minimizing that risk of having a large device like a 6 mil or 6.5 in those cases. So, a 10 mil might have been great for an ICA, but not great for the M1. And there's kind of a sweet spot in the middle that probably we all have literature to back up our numbers and back up our testing. But I think the fact that we've all come to around a 6 mil or 6.5 says a lot for what each individual company is doing to try to solve the same problem. And it does seem to be a sweet spot for managing an M1 clot and pulling that back into your intermediate catheter.
And Jeff, do you think that the 40 millimeter length was which most people use as standard for let's say again an M1 occlusion is based on the fact that we have equilibrium on both sides and we middle the device, and the standard M1 length being about 25 millimeters, which is why we chose 40 as our length? Is that the reason?
That could be the reason, actually. I'd have to probably go back to see exactly the science that went into that. We started with a 20 millimeter length and then, progressively got longer from there. I think 40, just like what Annalisa was just mentioning there with the diameter and kind of hitting that sweet spot, right? I'm not saying 40 is necessarily the sweet spot. I appreciate that there's longer devices, that are available in the market from various manufacturers. But, 40 millimeters, I think, matches well to the MCA. ICA typically covers the entire length of the clot, right? That covers most clinical scenarios, and certainly, as a company, we've done, lots of testing, as would, the other vendors as well, around what happens with these longer stents, right? And is there any risk of, or increased risk of vessel injury? And what can we measure? What dynamics are happening as a stent then is, pulled through an artery? And, in all of the data that we've looked at, all the testing that we've done, we've seen no increase in any sort of adverse event or vessel injury with the longer lengths. And so that 40 millimeters does, I'm not going to necessarily say it's a sweet spot, but it does seem to cover a wide variety of clinical scenarios. You can go shorter, of course, as well too, right? And there's many options that are available for maybe different anatomy. But 40 millimeters, just one of the themes I think that we've heard from a few people already here is simplicity also is an important thing, right? That user experience and not having too many choices and in the middle of the night. And if you can make it a little bit easier in terms of device selection that covers a wide variety of clinical scenarios, that could very well be, what's best.
All right. So, Shashwat, tell me practically, how should an operator choose his device in the middle of the night?
I think generally, in terms of stent retrievers, we have data now to show that longer stent retrievers lead to higher first pass effect. And it also gives you more freedom if you are slightly, proximal to the clot in terms of deployment, or the clot happens to be longer than we expect based on pre-treatment, CT or CTA. So overall, generally, longer is better. And I think most stent retrievers are in that 40 millimeter length range. The Supernova comes in 43 millimeters for the 4 millimeter device and 47 millimeters for the 6 millimeter device. And I think you are right. The lengths are based on the M1 and how the coverage happens. But in terms of choice, I think going for a decently long stent retriever with a good combined technique leads to maximum chance of first pass effect in the middle of the night. We want to, open up the artery in one shot, not having to clean and go back in, create first pass effect. So our approach is generally go for the longer one and then hope for first pass effect.
So, lots of times, Jackie, we have seen that we are at the supraclinoid ICA and there's a 90-degree bend out there when we have to go from the ICA to the ACA and M1 origins. So there's a 90-degree bend out there and our stent retriever comes across that. And obviously these are elderly patients with anatomy not being too great. So we aren't able to get a support distal enough where we would like it to be. It gets stuck somewhere at the ophthalmic because of calcium, because of extreme tortuosity, etc., multiple reasons. In that scenario, do you think what I want to understand from an engineering perspective is that as a neurointerventionist, what should be my drag? Should I do it slowly, extremely slowly? Does it increase the chances of bleeds? What are the dynamics across a 90-degree bend that a neurointerventionist should be wary about?
Thank you, Rajeev, for this question. So, of course, we are doing many testings with the flow models or with animal cadavers, but it's never matches your real life conditions, especially with a stroke patient. Again, early in the morning, of course, and most of the time your patient is under conscious sedation or awake, and it just adds up more problems to the situation. So there are two things here. One is keeping up with the engagement of with the clots. That's in these maneuvers, of course, within the bends, in the tight curves, the device may take a hourglass shape, partially or fully, and then you may lose part of the clot. So that longitudinal slit overlapping design helps to keep the clot in place while not allowing the stent is getting that hourglass shape as much as the complete section nitinol tube devices. Okay, so that's first to retain the clot inside. Second is that when you are pulling back on a device, of course, it tends to elongate a bit. That's nature. And when it's elongating, actually, it's at one hand, it's something bad because the cells are getting smaller in one direction, and it may cut the clot or lose some engagement with the clot. But on the other way, with the longitudinal slit design, when it's elongating, the cells are not getting as small and it's not elongating that much. Instead, that slit is helping the stent to get larger in the curves towards the convexity of the curve. And this way, longitudinally, the cells are working like a Caesar, and it is engaging, it keeps on engaging the clot. So that's the clot retrieval part of it. And for the safety part of view, again, if you're retrieving from A1 or A2, probably you are opting for a shorter device, not the longer one. So returning to our discussion with the length here. And of course, I think all of us have the shorter length for this because more anchoring is more modification of the anatomy. And you don't want to have like bleeding or dissection over the course. And also, it will provide you more predictable retrieval. You don't have this stretching, jumping phenomena when you're retrieving your device. So that's why length matters when you are going distal or from smaller vessel to the larger vessel. And the design of the stent also matters. I will just repeat the pinching technique, where it is essential to keep the clot in place, to lock it in place when you are coming from the smaller vessel to the larger vessel and in the curves, plus maybe playing with the level of the aspiration catheter or the intermediate catheter you are using.
So, Annalisa, what is the ideal material in your opinion when it comes to metallurgy of these stent retrievers? Do you think it's just nitinol based with visibility markers, or do you think we are yet to come upon a good material which can help in all these parameters we've been talking about?
Yeah, I think nitinol's pretty great. I mean, it's a pretty impressive metal, and there's a reason it's being used by so many or for so many different devices and treatments. So I think, I'm sure there are more innovations and materials that could help. But I also don't know if we're fully seeing our devices used to their potential. The Nitonol with the markers is a very good platform. Maybe there's things we can do around chemistry or biology to improve vessel injury, trauma, healing factors, clot grip. But I also think that because we're going into these procedures blind, because we don't know exactly what's happening with the clot or distal to the clot, and we don't know what the vasculature is distal to the clot, don't know what the clot type is, we're setting these devices up to not be used as perfectly as they were designed, because we're lacking knowledge. So I think, beyond even stent design, I think the next innovation that helps all of these devices perform better is technology that enables us to understand what's going on, what's going on in that patient. Maybe it's cameras, maybe it's sensors, maybe it's combined with AI to help us pick the right device, and take that guesswork out of it. I think the devices are quite good, and we aren't using them the best we can because we're lacking knowledge.
Right. But, an open question, it's a doubt really. Suppose we take a braided stent, like say a Leo or an Evo or something, and we can see every DFT wire. We can open it across a curve. We can fluff it. We can play with it. Is it possible technically, it's an open question to all you experts, is it possible technically to have a stent retriever that we can play around with? We know that the clot is in a particular location like A2 or M1 or whatever, and we can open it out there by playing with a braided kind of technology there, maintaining the radial force and maintaining all the other characteristics. Why don't we see such a device?
I think it goes back to some of the trade-offs that others were talking about before. We could make something really cool, but then ease of use is the sacrifice, for a lot of these. We have some funny toys we've got in the R&D lab that work extremely well, but are not simple to use. And that's with engineers who are well rested in daylight with models that we can see through. So putting those more complicated technologies that you can play with into physicians' hands at 2 a.m. when they haven't slept for 36 hours, they're not going to work as well as they do in the lab here. And it's not going to make the company many friends to have difficult to use technology. So there's trade-offs to it.
So it is, sorry, yeah, so it is technically, you're saying it's not so easy to make. So coming to our final segment, which is again open, and this is the myth busting round.
As long as it is safe and doesn't create trauma on the artery.
Okay, Jeff?
No, I might disagree. So we have our first disagreement here. I'm not sure that that's necessarily the case. I think, higher radial force, we've talked a lot about that already. There's trade-offs with that, right? I think you have to start managing dissections and, shearing perforators, and there's different considerations. So I don't think more radial force is necessarily better. So I'll put myself down as a disagree.
Disagree. Checky, what about you?
Disagree.
Disagree.
Totally aligned with Jeff.
Yeah. And Elisa?
Disagree.
Disagree. All right. So, Jeff, we've discussed this before, but just to summarize, do you think longer stent retrievers are generally better? Because the studies have shown us that longer the length, better first pass efficacy. So do you think if we have to choose between a 40 and a 50, we would be better placed to get a higher degree of first pass effect with the 50 rather than the 40?
I don't think it's as easy as saying agree or disagree. I might disagree only to say that, different anatomical considerations have to come into play. So a 40 might be better in certain scenarios. Maybe a 50 serves a clinical need. So I don't think it's as easy as saying one is certainly always better than the next. And some of it also just, defaults to physician preference as well. So a little bit of a loose answer there. I apologize. I'm not going super strong one way or the other, but I'd say if you had to hold me to one, I'd say disagree.
Right. Checky, what about you? I know you've discussed this earlier and you kind of aligned to this. So same thoughts as Jeff?
So thank you for giving me the clarification opportunity here. By having the 50 millimeter in our portfolio, I will still disagree with that and align with Jeff again on this because, longer devices, It's not our study even. I think it's other company studies that it improves the first pass effect. And the 90 days MRS score is not really changing between 30 and 40. I would say with inadequate cases, not 50. But what I want to emphasize, focus here is that choosing the length accordingly. As you mentioned early, with the tendon occlusions, with the high clot burdens, there's a place to use 50, and it's very successfully there. Instead of using 2 devices or employing different techniques, but not for all the cases. 40 is still the mainstream for us, and our device sales across the world is also showing that.
All right. So, Annalisa, you agree?
I disagree that length is always better. I think that what a physician needs in China is going to differ from what a physician needs in the US, and it's going to depend on the patient and the case. I think that the key here is that we've all provided choices for physicians to choose from. Some are going to be better than others depending on the patient and the case. So I disagree that longer is always better.
Shashwat?
I mean, I think I'll have to be at the other spectrum of this. Again, I think individual cases, we can intellectually decide, deliberate which one is better. But if you ask me a rule of thumb, I think longer is better, and it leads to higher first pass effect. So if you're unsure which one to use between 40 and 50 millimeters or between 20 and 47 millimeters, I would err towards the longer one, just because we have data that longer leads to higher first pass effect without compromising on safety. It's a known fact.
Right. Okay. Okay, coming to the next myth. All modern stent retrievers perform the same? It's a loaded question. It's got feel free to answer generically. There's no war out here. It's just, as an operator, because there's going to be so many operators watching this, it becomes confusing to us. We don't know what kind, like Shashwat was saying, we really don't know what kind of clot we're dealing with, despite all our imaging information. What do we choose? We have everything on shelf, and all the devices are fantastic. But it's a pain to do a pass, clean it, go back in, then another pass, and fragment it. So all of us here agree we want a good first pass effect. So do you think that all devices more or less are the same, or there are significant differences? I'm not asking you to, talk specifically about a device, but do you think that there is a difference between devices, or they're more or less the same? Just a yes or no. You start with Jeff.
I think on behalf of the entire group, I have to say disagree, because I think we're all trying to strive for, improvements in innovation and come to market with differentiating features that, improve patient outcomes at the end of the day. And I think a theme that has come through in this podcast is, ease of use matters, but really the user experience matters. So I think for neurointerventionalists, that user experience matters a lot. And I think it can be difficult, right? When you've got multiple manufacturers that are all coming to market with similar technologies, and you've got that choice in the middle of the night, that doesn't necessarily make things easier on you. So I appreciate your comment and how this can actually make things more difficult. But I think the beauty of this field is the pace of innovation is incredible, right? The pace of innovation that we've seen in neurointervention in the last 20, 25 years is almost unparalleled. So that's very special. I think it's something that is very commendable to all of the engineers and scientists who have contributed to that pace of growth over the last couple of decades. Hopefully that continues to improve. But that could also get harder, right? When you get more choice, it gets a little bit harder to determine which is the best in certain scenarios. So I certainly appreciate that can make things more difficult. That's not what we're striving for as an industry. It should be on making the user experience, the physician experience better, and ultimately a better patient outcome. So it's a balance, I think, that we still need to find, but I think we're all working in our own different ways to try and achieve that.
Right. So basically, I take your answer as, yes, there are differences, obviously, in the engineering philosophy, and there will be differences in the clinical outcomes based on user experience and familiarity with the device, because each I'll take an analogy of cars, like there are cars which some people like a particular brand, some people go in for another brand of cars, but it doesn't mean one is necessarily better than the other. They might have features which are a little different, and it's a personal choice. So maybe operator familiarity there. So, right. I know I don't mean to put you on the spot. I just wanted to know from an engineer's perspective, do you feel that, no, all stent retrievers are more or less the same, or they have differences? But I will not put you all on the spot by asking you all specifically. I do take it from you all that there are differences. But this question I want to hear from, I'll start with Shashwat. Do you think that the next breakthrough will come from understanding clot science better, like you mentioned the sensum wire, or it has to do more with change in the stent retrievers or the aspiration catheters?
I think it will come from both. As always, we need to understand the biology better to make better devices, better drugs, better treatments. So clot science is an integral part for any device design or any new treatment or technique. But I think there will be progress at the stent retriever design end. There's already extensive progress happening for aspiration devices. So we're going to see improvement at both ends.
And you all agree, feel free to pitch in, that it's going to be the clot morphology and understanding the clot science rather than really to do with the stent retriever metallurgy or the designs. So we have come to the last myth, that we have lots of proponents in the world who are very pro stent retrievers, and we have proponents in the world for aspiration. We will leave the combination aside for now, just for purposes of discussion. But in cost-sensitive environments, if somebody has to make a choice, an operator, by and large, I'm not going to customize it to a particular patient or the anatomy, or just to improve the first pass effect. Do you feel we should be stent retriever first, or do you think we should be aspiration first? Shashwat.
I think that's a very good question. We know that the highest chance of first pass effect in a large vessel occlusion stroke most likely comes from a combined technique, where you provide mechanical clot engagement with a stent retriever along with negative suction pressure using an aspiration device, and do a very comprehensive first pass, and that leads to first pass success. Now, adding a layer of economics to this, or cost-sensitive environments where adding a stent retriever, which is generally more expensive than an aspiration alone, should we still go for first pass or choose aspiration only? I think the answer to this is not to choose either or. The answer to this is to make combined technique as affordable as aspiration only. And that's what our thesis is, that let's not have to choose. Let's just make it more accessible.
So, okay, that's an ideal answer, an ideal environment. I hope this does work out, that we do see a reduction in the pricing to make it affordable for all. And it could come from many ways. It could come from insurance reimbursements, government-aided schemes, etc. So I know it's a very generic question, and I thank all of you for sparing your time and for participating so wholeheartedly in this and sharing your knowledge. I owe you all a glass of beer. So until the next time we meet, thank you again for being on Getting Wired. Thank you.
Thank you for having us.
Thank you.
Thank you. Our pleasure.
Thanks, Shash.